the International Society of Surgery, and he is also a colorectal surgeon and professor of surgery, assistant and dean and the head of the South Auckland Clinical Campus. Dr. Andrews, my dear friend, you start by your talk by RAS in colorectal surgery, the channel of implantation. Please.
Shukran, Professor Farid, and Assalamu alaikum to you all. Greetings from New Zealand, where I've come from. It's a very long way away, and time is very different. So if I fall asleep, please forgive me. I also bring you greetings from the International Society of Surgery in Zurich, and we have our Secretary General, Professor Boffard, sitting over there where I was just before. We will talk more about that this afternoon. Meanwhile, I would like to talk to you about enhanced recovery after surgery and the challenges of implementation. Now, some of you are old enough to remember 1995, and you may have read this paper in The Lancet. The senior author was Henrik Kellett, now a very famous professor of surgery from Denmark. And he described a small number of patients, 8 of them in fact, who'd undergone surgery and had been discharged very early from hospital. And forgive me if I read this out, but I think the words are very important. This is directly from the article. We attempted to provide stress-free colonic resection for neoplastic disease in 8 elderly high-risk patients by a combination of laparoscopy, epidural analgesia, early oral nutrition mobilization. Hospital stay was reduced to 2 days without nausea, vomiting or ileus. He went on to say that major advances in post-operative recovery can be achieved by early aggressive perioperative care in elderly high-risk patients undergoing colonic surgery. And I was extraordinarily impressed by this. We went back, I went to our hospital and we tried to introduce this, but found great difficulty in getting our service to change until I took a couple of our senior nurses to Denmark, all the way from New Zealand, and they found out what was going on and we were able to make some changes. Having said that, there's been a lot of work done in ERAS, and Henrik Kellett's work has been went on to show consistent differences over many years, and other groups have gone and done the same and have meta-analysed the data, and the data are very clear that this way of looking after patients undergoing colorectal surgery is almost certainly the way to go. Having said that, many places found it very hard to change practice. So the question I ask this morning is, why is it so hard to change behaviour? Well, the first problem, I think, and I've got 8 problems I think I'll address. The first one is that many people think they already do ERAS or fast track or an enhanced recovery program. The problem is that there is a disconnect between what we intend to do and what we actually do, and we all know about that in our own lives in practice, but in clinical practice it's definitely the case. In a study done by Atul Gawande's group, who's also very well known, called the Harvard Better Colectomy Project, they looked at 370 consecutive colectomies done in a particular program and assessed compliance with 15 key processes. They found that of the 15, there were 11 that there was difficulty getting adherence for in all patients. And you'll look to see down the bottom there that if they missed out if they did all of the key processes, they missed out none of them, the complication rate after surgery was only 7%. But if they missed only 4 of them, the complication rate became up to 42%, which is pretty much what you see when you actually closely analyse patients undergoing colectomy. So it's by missing out only 1 or 2 or 3 or 4 of these bits and pieces in a program that you have problems in getting the benefits from it. You can't just selectively pick it out. The second thing is, and I learnt this from going to visit his hospital, that there were a few things that Henrik Kellett didn't mention in his paper in The Lancet, nor in subsequent papers. And those 4 things were the role of the charge nurse on the ward, the dedicated ward for ERAS. He only actually did it in colons, he never described it in rectal surgery, and his patients were Danish, which I'll explain in a minute. So this is their charge nurse, is a lady called Dorte Hort, which is, I've pronounced entirely wrongly, but that's how it looks in English. And she is the old-fashioned kind of charge nurse. I presume you still have some of those here in the big hospital wards. But this is the kind of charge nurse everybody's a little bit scared of, including especially the junior doctors and even the senior consultants. I think we know the kind of person I'm talking about. But she was absolutely tough on this program. So once the program had been designed by Dr. Callett, she made sure that all the nurses and the junior doctors went through with the program, whether they liked it or not. And I found that it was very important to get our nurses to see the program in action, and that's why we took them to Denmark. There are now other ways to do that, but that was a very important way to get things done. The second thing was that they had a dedicated ward for ERAS patients. Now, that's not possible in most hospitals, but they're Danish and they're very organised. They say the Danish are more German than the Germans, and they were very organised about how they did things. And this was their dining room. The patients had to eat food in a dining room. So they would walk down the ward after their surgery. In fact, on the day after surgery, they would walk down to the dining room and they would have lunch or dinner together. So it was very important to get people mobilised, and the ward was very much about getting better rather than mixing up with acutes. When I've thought about it, the key was they took acute patients and elective patients and put them in different places. We've been able to do that in my hospital. Just by doing that, it made a difference of 1.5 days in hospital, just by doing that single one intervention. The third thing was they only did it in colons. Many people talk about colorectal ERAS. There's colon ERAS and there's rectal ERAS. Rectal is very different from colon. Rectal patients usually have bowel preparation. They often have a stoma. Many of them had radiotherapy beforehand, so they're different patients. Whereas the colon patients nowadays, many will not have bowel preparation. Only a few get a stoma, and they haven't had chemotherapy or radiotherapy usually. So it was very different. Also, interestingly, on this particular slide, this was from a later randomized control trial he did, where he compared open and laparoscopic for colectomies, and you can see that they had the same results for open and laparoscopic. They both went home at a median of 2 days. So when we talk about laparoscopic surgery being the be-all and end-all, perhaps not. The fourth thing was that all his patients were Danish. Now this is a mastermind question. One of these people is not Danish. It's the lady. She is the Crown Princess of Denmark, soon to be the Queen, and her husband is Danish, but she is actually from Australia. I'm from New Zealand, do not mix us up, but she is from Australia. But the point is, and I don't see many white middle-class European people in this room apart from myself, the point is that this was done in a certain culture at a certain time. And so your patients may well be different to the patients they had in Denmark. And so you need to make your perioperative care programs specific to your culture, your place, your environment. There are many things that can be different in different places. So Henrik's patients had some peculiar advantages that may not have elsewhere. The third problem is the attitude of surgeons. This is a study we did of colorectal surgeons in Australia and New Zealand, and basically you can see that many of the problems that surgeons described were problems with other people, not themselves. And we find it hard as surgeons to admit that we might be the problem. We always think it's someone else. So we also have to change when we are doing these things, and that's hard to do. Problem 4 is a failure to do it properly. If you try to introduce a perioperative care program just by saying we're doing this tomorrow, which is very much an old-fashioned way of doing surgery, and I still remember that, the surgeon is the boss, everyone else is down here. Well, it doesn't work like that so much anymore. If you're going to implement a change program in your hospital, you have to do lots of things. And this is an example of our old way of doing things. It's shown that preoperative fasting wasn't necessary in the 1980s, so you could actually give people things to drink up to 2 hours before surgery. The American Society of Anesthesiology made guidelines in 1999, and we still have overnight fasting in our patients, even though it was shown in the 1980s. We're currently nearly 40 years out of date with our fasting guidelines in many countries. So we need to have a different way of introducing things. And it looks a little bit like this. You need to have a team who look at the patient's journey through surgery, starting off with the outpatients, going through the preoperative preparation and so on and so forth, and follow them all along. And you need to make changes all of those places and you need to order the complications and the outcome. And this is the implementation strategy that is used by the ERAS Society and others. You form a task force to look through that program, you develop a protocol, it's reviewed by all of the key stakeholders, you implement the program, you audit the program, you look at problems, and then once a month or once every 2 months you feed back to your implementation, and then once a year you look at your protocol again, and you go around in this plan, do, study, act cycle every year to keep going, because it's hard to keep these perioperative care programs going. It's the key to sustainable practice. Problem 5, there was a lot of a lot of people are very enthusiastic about these programs. They get a little disappointed when things don't quite as they wanted, and then there's long-term neglect or strength. This is on the Isle of Man, a small island off the coast of England, and you can see the stone wall they're making in the foreground there. This was designed to make a harbour from this exposed bay. And as you can see, when I went and visited there earlier in the year, that stone wall has fallen down, and at high tide you could imagine that ships might in fact crash onto that boundary. And the point was, there's a lot of enthusiasm early on. The ships didn't actually come to the harbour. Everybody lost enthusiasm, and now it's actually more dangerous than it was before. So in fact, bad perioperative care is like this. If you start off with a lot of enthusiasm, build something, then it falls apart. In fact, bad perioperative care is worse than the perioperative care you started with. So you've got to do it properly, and you've got to sustain it. Now this is Liverpool. This is you've heard of the song The Yellow Submarine by the Beatles. This is their imitation of the Yellow Submarine, which to me was very disappointing. And the problem is with perioperative care, it doesn't look as cool as a robot. And surgeons, you can do it all by yourself with the robot. Whereas with perioperative care, you've got to do it with a team, and you have to interact with all sorts of people that maybe you wouldn't normally interact with or maybe work with as closely. And so perioperative care by surgeons is often seen, we often say, oh well, we'll just do it with a robot or with fancy laparoscopic instruments instead of trying to do it properly, which can be hard and challenging and difficult, but eventually does bear results far better than the robot does. This is also on the island the Isle of Man. And a lot of people think that if you just ignore something, it will go away. Well, it didn't go away with laparoscopy, and we've had to learn laparoscopy, for those of us who are a bit older in the room. And this was what the monks used to do. The Christian monks would, when the Vikings came to the island, they would climb up the top of that tower, they would close the thing at the bottom, and the Vikings would get bored and go away. And then the monks would come down and carry on with life again. And this is a little bit like what we do with perioperative care. You know, if we just leave it alone, it'll go away and we can keep doing what we always did. Well, if we do that, we will fall behind and we'll not be giving the patients the best we can. And here we are at a scientific meeting that is trying to be, with a society that's trying to develop the art and the skills of science and medicine as we do with the International Society of Surgery. I'm afraid we can't just let it go away. It's not going to. And problem 8, I think one of the problems is you saw that Henrik Kellett's protocol was very simple. It involved epidural analgesia, involved getting people mobilized, it involved feeding patients early, and so on and so forth. And this is where ERAS has gone now. Lots and lots of things you need to do, and only a few of them have been shown to make much difference actually. And some of them have been dropped. So for instance, stimulation of gut motility, he didn't mention it, but they use magnesium. Doesn't make much difference, but again, it's in there, and one more thing you need to think about. So, you know, I had an old, in South Africa they call these bakkies. I don't know what you call them here. We call them pickups or utes in New Zealand. What do you call trucks like this here? Pickups? Pickups, yeah. This is my, I had this truck a while ago. It's a beautiful truck, isn't it? Very beautiful. Very proud of this truck. This was my old Toyota Hilux. And it was very old. It had done 300,000 kilometers and was just warming up. It was a good pickup. This is what some people do to their pickups. This is not a good pickup. And so I learned this from a vascular surgeon. The enemy of good is better. And one of the problems with ERAS is people have taken what was actually a very good program and added all sorts of modifications to it and made it very difficult to use. This truck would be quite good for driving around parts of Cairo because you could drive over everybody, but wouldn't be much good on the desert road from Cairo to Alexandria because you were just lose control quite quickly. So it's like this with the perioperative care programs that have come along. We need to be very careful about developing ones that are relevant to our situation, ones that we can do ourselves, and ones that are simple, bearing in mind what Henrik Kellett did originally. So in summary, ERAS programs are here to stay. It's probably better just to call them modern perioperative care. Implementation is a challenge, as is sustainability. Obstacles are there all the time, but it is the future of perioperative care and we need to get on board. There are lots of challenges and problems. For many, the challenge is rebooting old and failing programs, and for others, it's getting one started in the first place and sustaining it. And lastly, I would ask, for those of you who have had an ERAS program going for a while, and those who are involved in the various societies around the world, are we making ERAS a bit too complicated and being the enemies of ourselves? Thank you very much.
Thank you, sir. It's a plenary lecture. We are not used to actually to open discussion, but exceptionally, being a guest from New Zealand, if there are any comments, we will welcome it for this IRAS thing. No comments? So the message is well delivered. Thank you, sir.